For the next session, I would like to invite the chairpersons, Dr. Anjali Agarwal ma'am, Dr. Chitra Pandey ma'am and Dr. Ritu Sinha ma'am to kindly come on the stage. I also request Dr. Prateek Tambe sir to kindly come on the stage for his talk. Chairpersons to kindly introduce the speaker.
Good morning, everyone. Today we are here to do a lecture on obesity. As we are all aware, it's a very major health concern, being a nutritional disorder of affluent as well as developing countries like ours. Therefore, due to very rapid nutritional and lifestyle transitions, in India, the urban prevalence of obesity has alarmingly risen to the tune that almost 50% of adult urban Indians and about 30% of children fulfill the criteria for either overweight or obese, which is itself a very huge burden. Obesity has a very broad and significant impact on many endocrinologic parameters. Obesity actually is rarely the result of endocrinological disorders, but the mere presence of obesity is associated with a number of disturbances in androgen, estrogen, serum hormone binding globulins, insulin and glucose metabolism, prolactin growth factor, and growth factor. Prolactin and growth hormone and growth factor metabolism. The hormone leptin, which is produced and secreted in the adipose tissue, affects the neuroendocrine reproductive axis both centrally and peripherally. And some of these alterations play a major role in the genesis of obesity-related ovulatory dysfunction, leading to fertility issues and pregnancy complications and metabolic disorders in females. Today we are blessed to have among us an extremely bright star of FOXY, Indian Society of Assisted Reproduction, and ICOG, Indian College of Obs and Gynae, Dr. Prateek Tambe, and he will be dealing with this subject. Now I request my co-chair, Dr. Ritu, to give you a detailed introduction of Dr. Prateek Tambe.
नहीं मैम ज़्यादा डिटेल मत करना.
Can you
मेरा time
please
खत्म हो जाएगा.
put the CV again? Can you revert it back?
बस
Please,
those
put
three
the
lines
CV
are
again.
enough.
Okay. Dr. Prateek, it's my pleasure to introduce Dr. Prateek Tambe to the house. We gynecologists know him very well, but it's my pleasure to introduce him to the house. Dr. Prateek Tambe is ART consultant and gynae endoscopic surgeon at Ashirwad Hospital, IVF, Mumbai. He has been an erudite scholar throughout and has received international diploma in advanced laparoscopy surgery in France. He's trained in assisted reproduction in Belgium, trained in clinical embryology and ICSI at London and Singapore. Sir has held many positions in the past, and presently he is the chairperson amongst Endocrinology Society. He has been conferred with many awards and prizes, recipient of 30 MOGS, AMOGS and ISAR and FOXY prizes. He has been editor of 24 books, 4 FOXY focuses and handbooks, and 11 key practice points. Sir has contributed more than 100 papers, invited as a faculty in more than 1,000 events, and has organized 800 plus CME. Sir has been convener to ICOG reproductive medicine courses. He is a peer reviewer, Journal of Obstetrics and Gynecology of India, Jogi, since 2012 and is still there. So we are very much happy to have you here, sir. The stage is all yours. Please deliver your lecture, sir.
Thank you, respected chairpersons. Thank you, IMA Allahabad. It's a pleasure and a privilege to be here at AMACON. My gratitude to the office bearers, Dr. Subodh Jain, Ashutosh Gupta, Anubha Srivastav, Dr. Lalita Shukla, Dr. Anjali Bagarwal, Dr. Mohit Jain, Dr. Anurag Verma. Thank you very much. If I have missed out any names, then the fault is entirely mine. I'm here to speak about a complex topic on which there are several other speakers. I'll try and restrict myself to fertility issues and obstetric complications. Now, both of these subsections of the talk are so long that I could comfortably speak for 2 days each and you would not get bored. Neither would I, but then we don't have time. There are plenty of other speakers and I don't want to waste too much time on introduction. Any fool can know. The point is to understand. Over the next 25 minutes or so, we'll try and understand what obesity is, how it impacts the entire reproductive course of a woman's life, and more to the point, what are the issues that we as obstetricians have to deal with now, which are totally different from what we saw 30 or 40 years ago when we were medical students. It's like we are relearning a new science, and as we go through the talk, you will realize that there are a lot of new vistas that have opened up. There are a lot of complexities which we were never aware of in the past, and we now have to deal with. So finally, whenever we start talking about something, I like to ask whether this is something which is relevant to clinical practice, or it's just some abstract concept, it's some emerging idea, or finally is it just a slot that is there in a 2-day conference which has to be filled by somebody. So you will agree with me that obesity is something which is burgeoning by leaps and bounds. This is WHO data from 2017, the most recent data that we have. And WHO themselves say that worldwide obesity rates have tripled since 1975. The last count in 2016 was 1.9 billion adults. I'm pretty sure this number has increased by leaps and bounds over the past 7 years since we have the past official statistics. 39% of adults are overweight, 13% obese. More to the point, 39 million children under the age of 5 have been found to be overweight. I'm pretty sure again that this number has increased significantly now today in 2023. If I can summarize that entire slide in one line as a take-home message, and that is really food for thought for all of us, it is that most of the world's population now lives in countries where overweight and obesity kills more people than being underweight. This is in contradistinction to what we saw in the 60s, 70s and 80s, where we were struggling to contain maternal morbidity and mortality and neonatal and infant morbidity and mortality as well. The tides have turned, the scales have changed very literally, where now instead of being underweight and malnourished, people are overweight and malnourished. So what are the associated medical conditions when we talk about obesity? I'm speaking to an august body of leading consultants from all over this city and of course India as well. So we know that BMI directly correlates with many NCDs including cardiovascular, diabetes, osteoarthritis and certain cancers as well. More importantly, when you look at obesity which happens in children and young adults, that's adolescents, you find that there is a significantly higher cause of premature death, disability, breathing difficulties, fracture, again cardiovascular morbidity, and insulin resistance with psychological issues, which will be covered by someone else. Let's talk about infertility. Infertility is something which WHO very recently has said has increased from about 5 to 10% to almost 20% worldwide. So is it of concern in obese couples, or is infertility just a general background issue? For this we turn to 2 or 3 very important references. The first of these is the American Society for Reproductive Medicine, which came out with a committee opinion from the practice committee, which is published in Fertile Sterile in 2021. We also have a FIGO review, and of these authors of note is of course Dr. Jaideep Malhotra and Professor Edgar Mukanu, both of whom are well known to us in OBGYN circles. This is a very recent paper published in Jan this year. And last but not least, we have a lovely paper which is published in RBE, which is specifically looking at disruption of female fertility and obesity. So what are the implications for fertility? ASRM says that obesity has adverse effects on reproduction. It's well known that obesity causes interference with ovulation, menstrual function, natural fertility and fecundity rates. It decreases the success rate of any fertility treatment that we offer, be it oral ovulogens, gonadotropins, ART. All of them have significantly lower success rates. We'll come to that in just a couple of minutes. It also reduces the safety of whatever fertility treatments we offer. And finally, it impacts obstetric outcomes, which is the last part of this talk. We know that WHO has laid down these particular points where we arbitrarily cut off into mild, moderate and severe as far as obesity is concerned. But let me remind you that these cutoffs are for Caucasian patients. These are for white people. These are for Westerners. BMI specific points for Indian population are 4 to 5 points lower than what the cutoffs are on that slide. So please remember that. Don't think that because somebody's BMI is 29, they are fine. No, the BMI cutoff for Indian population is 25. It's not 30. And this is what I like to remind my patients also, those of who are very Google friendly and they read up everything before they come to us and they say, Doctor, I'm fine. I'm only 90 kilos. It's absolutely okay. I can carry a twin pregnancy also. There shouldn't be any problem. You go ahead and treat me. And then I have to drill it into their heads that they have to optimize their weight before the treatment cycle to have a good live birth and take home baby rate 1 year later. That's something which we as clinicians don't often talk about and which Google also doesn't educate patients. We may think that Stein and Leventhal were the first people to describe polycystic ovary disease, but if you go back in history and read, the French surgeon obstetrician Ambroise Paré was the first person way back in 1633 who described PCOS. Of course, he had not done surgical dissections, he had not looked at the ovaries, ultrasound was not invented then, so he didn't know he was describing PCOS until Stein-Leventhal came 300 years later and described polycystic ovarian disease. As far as description of menstrual irregularities and hormonal fluctuations is concerned, a good grounding in the rise and fall of FSH, LH, estrogen and progesterone is of paramount importance before we talk about these. But today's lecture is only 25 minutes, so I won't be able to describe this slide in detail. We will go straight on to the problems that occur when a woman is obese. And for this, we turn to the study of women's health across the nation, the SWAN study, which reported that once a woman is obese, you can have menstrual cycle irregularities between 10 to 50% of the population. Again, childhood obesity at 7 years is an independent predictor of menstrual problems by the age of 33, and a meta-analysis, probably one of the largest, of 53 studies with nearly 1.5 million treatment cycles, shows very clearly that BMI impacts ART success rates. So what is the impact of this anovulatory infertility on the diagnosis of PCOS and BMI? If you look at a BMI of 30, your relative risk is approximately 2.7. Again, these figures are for Western civilization. So a woman in India with a BMI of 26 will behave the same as a Caucasian woman of 30 plus. This is what we need to understand, and this is what we need to convey to our patients. It's not fine to say 90 kilos is fine, BMI of 29 is okay. It is definitely not okay. This is a very old paper. It's almost 30 years old, but I've been using this to counsel my own patients since the past 20 years. And what this tries to show is that with a small increase in BMI of just 25 to 27, your chances of getting pregnant significantly go down. Your risk of infertility goes up in what we call in mathematics geometric proportion or logarithmic progression. This is our two-cell to gonadotropin theory, well known to all of us. The reason I'm showing you this slide is because the theca cell is the one which generates androgens. The granulosa cell is the one that generates estrogens. In women with PCOS, and the reason we are talking about PCOS is because 80% of women with PCOS are by definition obese, and the largest proportion of obese classic PCOS anywhere in the world is right here in India. These theca cells are 3 times the number of granulosa cells, which means by definition these women have tons of testosterone and dihydrotestosterone, both bound as well as free in their plasma. And what happens because of this excess of androgens? You have a completely altered endocrine profile where you have a lower total cycle LH, decreased follicular LH amplitude, lower amount of FSH as well, longer follicular phases, poorer quality oocytes, lesser number of developed oocytes, shorter luteal phases, decreased progesterone, all of which contributes to decreased fertility in natural cycles also if these women manage to ovulate. If you pump gonadotropins into these women, it's going to amplify all of this, and you need to correct all of this. And how do we correct it? We'll come to that in just 5 minutes. As we said, there is a complete alteration not only in the ovarian steroidogenesis, but in all the systems of the body, including the liver, reticuloendothelial system, and the metabolic, how can I put it, milieu of the patient. This is a very long slide. I'm not going to be able to read it out, and this, I will put it very humbly to you, is what we know as of today. We didn't know this 20 years back. We didn't know it 30 years ago when I was a medical student. And there are many things which we still don't know today, which somebody will come 10 years from now and say, okay, this is all old stuff, ये सब historical बातें हैं, इससे बहुत आगे अभी science बढ़ गया है. But the key here, what I'm trying to convey to you, is that your alterations in SHBG, your sex steroids, leptin and adipokines, as madam mentioned just now, all of these add up to a complex, what we call perfect storm, which is just waiting to happen, which ultimately results in metabolic syndrome. Today we are not going to talk about metabolic syndrome. I am restricting myself to fertility and obstetric complications. So here I must mention that these adipokines and these leptin and ghrelin hormones specifically are the ones which we have now learned impact all the body systems, both in the short as well as the long term. Is there an altered ovarian response when these women undergo fertility treatments? Yes, there are much decreased chances of ovulation when they are subjected to oral ovulagens. Many women are now known to be even gonadotropin resistant. They require significantly higher doses of medications, produce lesser number of follicles. There is a much longer duration of therapy, higher consumption of ampules of FSH, what we call increased cancellation rates, and fewer oocytes are retrieved. If you take the follicular fluid and you study it under the microscope and you subject it to, apologies for that, if you subject it to biochemical analysis, you will find that there are much higher levels of insulin, greater levels of inflammatory markers, reactive oxygen species, higher levels of free fatty acids, abnormal COCs, smaller oocytes, dark cytoplasm, what my embryologist likes to call it, lesser blastulation rates, all of which means that your embryo quality is going to be sad, and the chances that the woman will get pregnant will be significantly lower. If you've managed to make the woman ovulate, you've managed to create embryos, now we have new challenges to deal with. Women who are obese have significantly altered endometrial receptivity. The gene expression which is required for embryo and blastocyst implantation is not there in these women. Everything looks fine, endometrial thickness is good, blood flow is fine, but when you do a biopsy and see, you subject it to endometrial receptivity markers, you will find that these women have lower chances of implantation, they have a significantly greater risk of miscarriage, and this is in spite of having good quality euploid embryos. 20 years back we didn't have PGTA to look for whether the embryos were euploid or aneuploid. Now we do have it, and we realize that even if the embryos are normal, they are 46XX or 46XY with absolutely no translocations, no ring chromosomes, none of that rubbish, still the chances of pregnancy are significantly lower. In practice, how do we counsel these women before we start fertility treatment? This is a lovely table which I found, and this is again published based on SART data. with nearly 52,000 cycles from 2015, and this is published in the ASRM Practice Committee Guideline. Any of the references which I have talked to you about, in case you're interested, they're available freely on the internet. You can't find them, send me an email, I'll share them with you. What happens is, if you look at the BMI on the left, the BMI on the top and the age on the left, depending on that, the patient is either in the red zone or she is in the green zone. We are not so concerned about the green zone, we are more concerned with the red zone. And you will find that women whose BMI is 35 or above very quickly have chances of pregnancy in single digits. And as I said, for Indian patients it is 5 points lower. So the moment she hits 30 BMI, straight away her chances of pregnancy go down significantly. She may go to the best clinician in the world, she may go to the best clinic in the world with the best success rates, but ultimately she will not have a take-home baby simply because she is obese and she has an altered endocrine milieu. We know that there are several obstetric complications as well which happen, and we will talk about those in just a minute. This is from ESRM: gestational hypertension, diabetes, cesarean, stillbirth, LGA babies, macrosomia, shoulder dystocia, congenital anomalies, and NICU admissions all are significantly higher. Just 2 slides about male fertility, because we have to talk about male fertility as well, and obesity. We know that men are becoming significantly more obese because of westernization, stress, long working hours in a country, in a city like Mumbai, where we travel for 3 to 4 hours a day. We are exposed to a lot of pollution, and of course we know that we are all the time surrounded by stress. There is a significant decline in semen parameters: oligoasthenoteratospermia, erectile dysfunction, diabetes, sleep apnea, DNA damage, mitochondrial damage, which sometimes doesn't show up until you create your embryos, and your chances of live birth rates are significantly lower simply by virtue of being exposed to that toxic environment. Coming to the management approaches, when we talk about management of obesity and PCOS, the most recent guideline is the one which is there on the screen. It's published by ESHRE, ASRM, and it is here now in August of 2023. It's 216 pages, so if it's long, boring, and tedious, this is the shorter version with just the key recommendations. Again, the reference is there at the bottom in case you want to look it up. And here they talk about the relation between BMI and fertility. This is an old paper. What they found is that if you want to kickstart fertility, all you need to do is that women need to lose 5% of their body weight, and within a 6-month period, 80% of them had regular menses, 60% had ovulatory cycles, 40% became pregnant spontaneously. You do not need to wield a Brahmastra. You do not need to do IVF. All you need to do is ensure 5% weight loss and ensure that it is maintained until the woman gets pregnant and beyond. That is all that is required. And people like me who depend on IVF as their bread and butter will be out of a job tomorrow, if we are able to convince our patients and if they can adhere to their treatment regimen. In fact, this is known since 25 years. This is Professor Rob Norman's paper published in the BMJ, where he talked about 3,500 women, and they found that if the BMI was 30 to 35, the outcomes were reduced by 30%, BMI more than 35, outcomes were reduced by 50%, irrespective of which treatment regimen was used. More papers ascribing to the same. Another paper here which talks about lifestyle interventions. This is published in August 2021. With just a simple lifestyle intervention, your clinical pregnancy rates and live birth rates skyrocket. That is all that is required. You do not need rocket science. You do not need complex drug therapy. So what are the management principles for obesity? Obviously, we can't be fat 100 kilo slobs. We need to set an example to our patients. Always involve an endocrinologist, because there are certain endocrine abnormalities which you will miss. Have a good nutritionist on your team, a personal trainer, and women need periodic reinforcement. They are with us for just 10 minutes when they come for consulting, but it is required to have periodic reinforcement. Again, this is something which somebody else will talk about, but you need to evaluate what are the different parameters which will ensure that she continues her treatment. Basic diet do's and don'ts which all of us recommend to our patients. As far as lifestyle recommendations are concerned, Eshre says you need to have a caloric deficit, set smart goals, achievable goals, just 5% to 10%, specific, measurable, achievable, realistic and timely. But the key message that Eshre gives, and which we should also convey to our patients, is that there has to be a lifelong focus on prevention of weight gain and maintenance of the weight loss once it has happened. That little graph that you see on the right side is my exercise data for the entire last year, 2022. There's one good thing that has happened thanks to smartphones. By and large, they make us slaves to them because they keep giving us dopamine hits periodically and we are become slaves to them. But if you have a good smartwatch and a companion app, then it will give you good data. It will tell you that last week you were doing well, this week you are not so good, last month you were better, this month you are not doing so well. And that little feedback and motivation is required, which you and I as doctors cannot give to our patients. The recommendations from Eshre and ASRM are very clear: 120 minutes per week for maintenance and 150 minutes per week for weight loss. I'm going to skip past these slides because I want to go to the obstetric complications. Can we control androgen excess? Unfortunately, it's difficult because there is a vicious cycle of hyperandrogenemia and hyperinsulinemia, and we need to cut it short somewhere. The way to cut it short is to ensure insulin sensitization. What is the best insulin sensitizer? If I can ask the audience. Exercise is the best insulin sensitizer. It is not metformin, it is not myonisitol, it is not dichloroinositol, it is not berberine. The best insulin sensitizer is persistent and maintained exercise. The long-term complications are known to all of us. Again, this is an august body of doctors. I don't need to tell you that you have impaired kidney function, fatty liver disease, then you can have metabolic syndrome with all its attendant complications. But this has to be conveyed to our patients. This is a very new paper. I just came across it 2 weeks back because it's published just 2 weeks back. And this looks at the, no, this is actually a paper which came out yesterday. This is from JAMA Open, and it says that the best predictor of long-term mortality after obesity diagnosis is not BMI, it is actually the waist-hip ratio. And they followed up nearly 4 lakh patients over 17 years to come to this data, and they found that if you look at just the humble waist-hip ratio, which requires only a simple tape measure, you take it at the right points, you'll be able to predict cardiovascular and other mortality with adiposity much better than the old traditional tools. The tools for long-term success, again somebody will talk about this a little later. I'm not going to talk about this. Self-monitoring and journaling is very important because it gives the patient constant feedback about what she's eating, how she's doing, what is her mental status. New evidence regarding insulin sensitizers. Metformin works at the level of the insulin receptor, whereas your newer inositols work intracellularly, therefore they might be better. Inositols are now also recommended by the Eshre guideline as no longer experimental. They should be part of our armamentarium. The obstetric complications, just to wind up the talk. For this we turn to another lovely paper in BMJ published in 2017, and there is the ACOG practice bulletin which was published in June of 2021. Miscarriage risk 1.67 times higher even if the patient has had oocyte donation. 58% of these are euploid miscarriages, which means they don't have a chromosomal cause. Neural tube defects like meningomyocele are significantly more. Limb reduction defects, cardiac anomalies, cleft lip, cleft palate, all of them are increased. Diabetes, hypertensive disorders of pregnancy, preterm labor, stillbirth, all of them are increased across the board. Failed trial of labor, cesarean, endometritis, repeat cesarean section, twice the risk of morbidity, 5 times the risk of shoulder dystocia, the most common cause for litigation in the Western world. I'm pretty sure it's coming to India as well. We are not very far behind. Surgical site infections and infections are also more common. Higher chance of pulmonary embolism, therefore thromboprophylaxis is important. Postpartum depression again is much more common. And all of us are familiar with the Barker hypothesis, where the fetal origin of adult disease is very well described. This is how it happens. Again, we are out of time, so I'm not going to talk about this. So a few simple key practice points and protocols which we did. This is in 2019 when I was the Foxy chairperson. We developed a patient information booklet, 7-step guide for counseling, checklist. This is the international AWARE group which collaborated with us to develop a counseling tool for patients who are diagnosed with PCOS. We've developed new guidelines for acanthosis nigricans, which is one of the pathognomonic markers for both metabolic syndrome as well as PCOS. That's being published in JAPI in just a couple of months. We are aware that there is a lot of treatment options for morbid obesity. Again, somebody will be speaking about this. But we're coming out with Indian national guidelines for surgery for morbid obesity and the medical management very soon through the Indian Society of Assisted Reproduction. So to conclude my talk, ladies and gentlemen, obesity is now the hidden pandemic. We need to tackle it on a war footing. It has far-reaching implications for fertility, pregnancy, and the long-term life and health, not only of the patient, but also society and this wonderful nation. We need to address the issues of significantly higher maternal and neonatal morbidity and mortality. And I don't need to tell you that prevention is better than cure. We need to convince our patients that addressing obesity before a woman gets pregnant yields significantly greater benefit than treating it later and treating the complications during pregnancy. Thank you for a patient hearing. Thank you again, AMA, for inviting me.
Thank you so much, sir, for such a comprehensive and insightful talk and covering such a wide topic in such a short time. I would just like to know, sir, what is your experience of bariatric surgery before planning treatment for infertility or obstetrics or pregnancy?
So we've had some patients who've undergone bariatric surgery and then come to us. So usually you need to take a break of about 12 to 18 months before the entire metabolic system is normalized. If they've had a balloon, then that is the best way. If they've had a band, that is the best bariatric surgery, because in pregnancy, when they have malabsorption, they have hyperemesis, they have weight loss in pregnancy, they're not gaining weight, then that band can be sort of relaxed. But by and large, women who undergo bariatric surgery need to have a little bit of a break before they plan pregnancy. Again, the complications that result from bariatric surgery, the basic surgery, are simply lesser. Those who undergo more complex procedures like Roux-en-Y and sleeve gastrectomy, all of those, the chances of issues are significantly more.
And they have to be advised contraception for 8 to 12
Absolutely.
months.
12 to 18 months is the break that we recommend.
Yeah, okay. Thank you. Thank you so much.
Now for the